Hello, we're glad you've joined us for this live webinar, A Clinical Perspective on Sexually Transmitted Infections. What is the state of play? I am Judy O'Rourke of LabRoots, and I'll be moderating this session. Today's educational web seminar is presented by LabRoots, the leading scientific social networking website and provider of virtual events and webinars advancing scientific collaboration and learning. It's brought to you by Abbott Molecular. At Abbott, we're committed to helping people live their best possible life through the power of health. For more than 125 years, we've brought new products and technologies to the world in nutrition, diagnostics, medical devices, and branded generic pharmaceuticals that create more possibilities for more people at all stages of life. Today, 94,000 of us are working to help people live not just longer, but better in the more than 150 countries we serve. To learn more, visit www.abbott.com. Let's get started. You can post questions to the speaker during the presentation while they're fresh in your mind. To do so, simply type them into the drop-down box located on the far left of your screen labeled Ask a Question and click on the Send button. Questions will be answered after the presentation. To enlarge the slide window, click on the arrows at the top right-hand corner of the presentation window. If you experience technical problems seeing or hearing the presentation, just click on the Support tab found at the top right of the presentation window, or report your problem by typing it into the Answer a Question box located on the far left of your screen. This is an educational webinar and thus offers free continuing education credits. Please click on the Continuing Education Credits tab located at the top right of the presentation window and follow the process of obtaining your credits. I now present today's speaker, Dr. John White. Dr. White is a sexual health physician and has been editor-in-chief of the International Journal of STD and AIDS since 2009. After training in Sydney, Australia, he worked as a clinician and researcher in the Department of Genitourinary Medicine at Guy's and St. Thomas's hospitals in London for many years until late 2017. He recently moved to Northern Ireland and now practices at the Altnagelvin Hospital in Londonderry. Dr. White's clinical and research interests include bacterial STIs, sexual health for men who have sex with men, and diagnostic tests for HIV and STIs. He has a keen interest in lymphogranuloma venereum infection and is involved in several research studies involving the assessment of diagnostic tests for bacterial STIs and HIV. Dr. White will now begin his presentation.
Many thanks, Judy, and hello out there to everyone. Thanks for joining this webinar. I've been asked to speak today about sexually transmitted infections from a clinical perspective, which is a fairly daunting task given the size of the topic and its very global scope. But I hope that during this hour I can cover some of the major ground and share some of my thoughts on the current challenges that we face and particular issues of concern. In terms of disclosures, I'd like to disclose that I have received gonorrhea and some research support from various diagnostic companies in the past few years. And today's webinar has been requested by Abbott Molecular, although the content has all been put together by myself, and these are all of my own views. So, by the end of this session, I hope that you're able to understand the latest epidemiological trends for the major STIs with a focus on high-risk groups for STIs, including MSM. Also, I'd like to make you aware of recent developments in diagnostic tests for STI pathogens, and particularly the advantages of molecular assays and the importance of the extragenital reservoirs. And hopefully you'll appreciate the challenges of treating bacterial STIs in an era of increasing antimicrobial resistance. This is especially pertinent for Neisseria gonorrhoeae and Mycoplasma genitalium infections. So, the epidemiology of STIs, you can't really sum this up in one slide, but there are at least 30 different organisms that can be transmitted through a variety of different types of sex. And the most recent global estimates from the World Health Organization are that there are annually nearly 360 million new infections, with just the 4 main curable STIs, those being chlamydia, gonorrhea, syphilis, and trichomoniasis. So huge numbers that we're talking about there. And in addition, over 500 million people are infected with genital herpes simplex virus, Nearly 300 million women have a genital HPV infection. And the key point about STIs is that most of them have no symptoms or only mild symptoms, and therefore they might not be recognized or diagnosed or even considered to be caused by an STI. Now, of course, HIV and the viral hepatitis, particularly hepatitis B virus, are also sexually transmitted, but I've considered them to be beyond the scope of this presentation because it's quite hard enough as it is without having to include those. Now, nowhere in the world is really safe from sexually transmitted infections, and wherever you work, I'm sure they will be there. But there are certainly hot spots and cold spots for each pathogen. And looking back at those 4 infections that I just mentioned, the majority of those bacterial infections are seen in Africa, in the Western Pacific, which includes China, and both the Americas. Now, it hasn't all been bad news when it comes to figures, and certainly in recent decades there have been some positive developments, and the 2 infections, chancroid, which is caused by Haemophilus ducreyi, and donovanosis, caused by Klebsiella granulomatis. The rates of both these infections have been decreasing, and now they're considered to be quite rare in most settings. So that's really good news. And in addition, as a result of human papillomavirus vaccinations, we've observed a decrease in precancerous lesions and in genital warts following the rollout of HPV vaccination in those regions. And the global epidemiology of HPV certainly looks like it's going to change quite dramatically over the next decade, and that's great news. And it goes without mentioning there have been huge successes globally with HIV and AIDS in terms of its prevention and its management, but I won't discuss those further here. But nonetheless, every day, millions of people continue to be affected by sexually transmitted infections. And anyone who's ever had sex is potentially at risk, but there are certain groups who continue to be overrepresented in prevalence and incidence studies, and these groups are really important to access in terms of any clinical or programmatic setting for STIs. And it's worth mentioning these groups. I mean, young people and adolescents at a time of sexual debut, particularly vulnerable to some infections, specific ethnic minorities, depending on where you work, men who have sex with men, who I'll refer to as MSM for short, transgendered people, people already living with HIV, often affected more by other STIs, sex workers and the clients of sex workers, geographically mobile populations, prisoners, drug users of various drugs, and people who are affected by conflict and civil unrest. So, you know, any of those groups might be important to address locally as far as STI care goes. Now, why are STIs important? Well, why do I do the job that I do, I suppose? But in some circumstances, STIs can kill people or they can maim. And I think syphilis is probably a perfect example of this. And I think we've been very fortunate to live in an era where syphilis has been treatable over the last century. And perhaps many of us don't really appreciate the full scale of syphilis morbidity and mortality that existed in the pre-antibiotic era. But even if an infection doesn't kill you, it can certainly compromise quality of life for many individuals, and STIs certainly do that in a lot of different ways. They can have adverse effects on the sexual and reproductive health, particularly of women, especially gonorrhea and chlamydia infections. Many STIs are harmful to babies and young children, and HIV is transmitted and acquired more easily in the presence of STIs, in particular genital ulcer diseases such as herpes and syphilis. STIs, especially HPV, as I mentioned, are risk factors for cancer, and globally there's a huge financial impact of STIs, not only on individuals, but regionally and nationally, and unfortunately this is often worst in poor countries. So really there are many reasons why I think we need to diagnose and treat or prevent STIs, and there are many benefits to improving sexual health in populations. Now, in terms of my current clinical setting, what kind of diagnostic tests do I need or do I use in my clinic and in my lab? Certainly routinely I would use in-clinic microscopy, so not only for gram stain, but we do wet mount preparations, and in particular dark field microscopy for lesions that we suspect of being caused by syphilis. Routine rapid tests or point of care tests that we can do in the clinic. I mean, simple things like urine dip for urinalysis, urine HCG testing for pregnancy. We do point of care testing for HIV, and then we can send tests to our local laboratory for gonorrhea culture, Trichomonas culture, and Candida culture where relevant. Our local laboratory does combined chlamydia and gonorrhea nucleic acid testing using the Roche-Cobas assay, and any gonorrhea positives that we have locally we can confirm using the GeneXpert CTNG assay. We have to refer samples either to Belfast or to London, and we use those tests that are usually in-house PCR tests for herpes simplex type 1 and 2, for T. pallidum PCR, for LGV DNA testing, as well as Mycoplasma genitalium testing and resistance testing for Mycoplasma genitalium. And locally, our serology, we usually test using enzyme immunoassay for HIV, hepatitis B and C, and syphilis. Any syphilis that is positive, we also then subsequently test using TPHA and RPR. Okay, so now focusing on the specific STIs, perhaps let's start with gonorrhea. And this is caused by the organism Neisseria gonorrhoeae, which is a gram-negative bacterium. And it classically causes lower genital tract infection in men and women, and that can subsequently be complicated by ascending infection to cause salpingitis and PID in women and epididymitis in men. Gonorrhea can occur in the rectum and the throat, and these are the major sites of infection in MSM, although women can also be affected in the throat and the rectum, and indeed some heterosexual men that we see also are infected with throat gonorrhea. Women can pass this infection on to neonates during birth, and anybody who has a mucosal infection with gonorrhea, rarely it can spread to the blood and then often onwards to the joints, and other organs rarely in the body can be affected by gonorrhea. Rare, but a very severe infection indeed. And the eye is one place that you really don't want gonorrhea, as it can cause a really severe conjunctivitis both in neonates and in adults, and this can result in permanent corneal damage. Rates of gonorrhea will vary according to the region that you're working in, but these are some recent figures from England where we have very good surveillance of STIs, and they're probably typical of many Western settings where we've seen an increase in the numbers of gonorrhea infections over time. And that graph shows a very disproportionate rate of infection among men, and what this represents is a significant burden of gonorrhea infection in MSM. And I'm not sure if that reflects what you're seeing locally, but yeah, there's certainly been an increase in gonorrhea in many settings in the last decade. Now, in much of the world, diagnosing gonorrhea is done clinically or syndromically, but if you have a microscope, this is still a very good test for seeing the typical gram-negative intracellular diplococci in an inflammatory discharge. But in reality, it's really only a sensitive test in men with symptomatic gonorrhea urethritis. But nonetheless, it's still a very quick, cheap, and a useful test, and I use it every day in clinic. But culture has been the main way of achieving a definitive diagnosis of gonorrhea for many years, and it also has the advantage of enabling the determination of antimicrobial resistance on the plate, and this is really important for this organism. The nucleic acid amplification tests, which I'll refer to as NATs, have become the new gold standard in the last decade for certainly sensitivity as far as detecting gonorrhea goes. And they're now the primary tests that are used for detecting gonorrhea in most well-resourced settings. Now, GC NATs have evolved to be both highly sensitive and mostly very specific, although some individual assays can still generate false positives if they detect other commensal Neisseria organisms, which are often present, particularly in the throat. And so most labs will need to have alternate assays to confirm any initial GC NAT positive results, particularly if they've come from areas such as the throat or the rectum. But in general, NATs are great because they're much more forgiving regarding storage and transport conditions for specimens. And this has really enabled sampling to be done in a much wider range of settings, such as outreach or at remote clinics, rather than a clinic that's right next to a big laboratory, which you often need for culture. Another big advantage of GC NATs is that they've enabled us to develop the use of less invasive specimens, such as urine and self-collected vulvovaginal swabs. Whereas still for culture, if we want a GC culture taken, we have to take a painful urethral swab from men and endocervical swabs from women. And these are really uncomfortable for patients, and they're quite resource intensive to collect. So self-collection and home sampling are both innovative ways that these tests are now being used. It's not all good about GC NATs. The downside is that traditionally they don't really give us anything but a positive or a negative result. So we don't get any information on whether the organism is still alive or dead. And that can be important if you're testing somebody not long after they've been treated. In addition, we don't know whether there's any antimicrobial resistance present, and this is really crucial in the current era. Now, there are some new NAT assays that are emerging that can also detect markers of resistance or sensitivity to antibiotics, and this can be helpful if it is a result where not only we know that gonorrhea is there, but we know that this is a strain of gonorrhea that will respond to a particular drugs. And this has been used especially for quinolone drugs in recent years, and tests like this are going to be vital going forward, particularly where culture results are unavailable. And one such assay that's recently come to the market is a test from Australia, the SpeedX test. In terms of the GC culture, the GC NATs have really come into their own when testing MSM. Now, most MSM have gonorrhea infection that's usually extragenital, and it's usually asymptomatic. And here's a big study that we did in London nearly 10 years ago now, and we looked at over 4,000 MSM attending our services. And when we tested everyone using NATs at those 3 sites, we found that the rates of gonorrhea were much higher at the throat and rectum than they were in the urethra, and most of these were asymptomatic. And even when you compared paired samples where we took cultures from all these sites as well, culture was still a good test for the urethra. But when you look at the rectal site, we were only able to culture about half of the infections that were present in the rectum. And when it came to the throat, about only 1 in 5 MSM were able to have a positive culture from the throat. And so in this cohort, had we just tested with culture, we would have missed more than half of the gonorrhea, and these men would have gone undiagnosed and untreated. Now, given that these results more or less mandate the use of GC NATs for testing MSM at all 3 sites, the use of 3 separate samples per patient is quite expensive. And we did a study in London looking at the use of pooled samples from the throat and rectum and urine and combining them into 1 sample for analysis. And this was published in JCM in 2016. And our results, as well as those of other investigators who've since replicated this work, have found that the pooled sample performs well in MSM as well as in women. And going forward, this may be a much less expensive way to screen effectively for not only gonorrhea but chlamydia as well. And whilst a positive result might not always indicate which of the mucosal sites were infected, in practice we found that provided we treat the patient, we rarely find that this is of clinical significance. But clearly the tests don't have a claim or a license for this at the moment, so it really does depend on your local setting and what you're able to do with your NAT testing. As far as rapid tests go, well, there are rapid tests available for gonorrhea. Because, I mean, whilst GC NATs and culture are great, the results usually take days to appear, and that doesn't always help the patient that's in clinic with you today. And the Gram stain is the original rapid test, and as I've mentioned, it's still a good test, but really only for male urethras, and it lacks sensitivity and specificity in other sites. Now, antigen-based tests have appeared in recent years for gonorrhea, but their performance has been very disappointing, and none can yet be recommended for routine use. More recently, rapid NAT-based assays have emerged, and these certainly have the potential to improve clinical pathways for gonorrhea, especially in settings where lab results can take sometimes weeks to get back to the clinic, or you might have patients who might not be able to return easily for treatment. Now, there's various companies that have tests that are available now or will imminently be available, and I've listed some of these here. The time to results, it varies depending on the platform from maybe 5 to 10 minutes up to 90 minutes, and some tests that take 90 minutes might not be considered to be particularly rapid, but certainly these have the potential to improve syndromic management algorithms and enable much better antibiotic stewardship, particularly in settings where overtreatment is currently common. But in the UK settings where assays like this have been used, the same-day results that have been available have been really popular with patients, and they've certainly enabled a significant reduction in the time from test to treatment when it's occurred. And why is antibiotic stewardship important for gonorrhea? Well, it's become a superbug in recent years, and if you're not aware, since antibiotics were invented, gonorrhea has always had the ability to evolve into a new strain that's been able to evade cure with the antibiotic of the time. And as you can see from this graphic, we're now starting to run out of drug classes to treat gonorrhea effectively. Super gonorrhea, as you can see there, it's of course it's all over the news, and this is a report just from the BBC News last week where there was another couple of cases of extensively drug-resistant gonorrhea that were isolated in 2 women in the UK. Now, it's likely they were acquired outside of the country, but it does suggest that we're going to be seeing this more commonly. Now, ceftriaxone resistance has been increasingly prevalent in the Far East over the last decade, and it does seem that it's about to move this way. And in the last few years, there have been several treatment failures that have been described with the first-line dual therapy of ceftriaxone and azithromycin. So people are really starting to panic because there are really now well-founded concerns about untreatable gonorrhea. Now, how do we treat gonorrhea? Well, currently most GC management guidelines worldwide recommend dual treatment with varying doses of ceftriaxone and azithromycin together. And the various doses probably reflect the lack of clear evidence about what the best regimen really is. Now, unfortunately, azithromycin is becoming increasingly resistant quite quickly, and that has rendered dual therapy less effective. And now that there are cases of ceftriaxone resistance as well, we're really not sure which drug to go to next. Looking across the surveillance in Europe, these are the latest figures from 2016, which showed that there were no ceftriaxone-resistant isolates that had occurred, but clearly in 2018 and 2019 there have been a few reported now. Not so for azithromycin there, where across the board resistance was seen on average in 7.5% of settings, but that has been increasing quite significantly, and the same certainly been seen in the US and in other parts of the world. In the UK, we have very good surveillance of gonorrhea resistance, and looking here, you can see here quite a sharp jump in azithromycin resistance in 2015 and 2016. And that has continued, and some of those isolates have been highly resistant to azithromycin. So what do we do in terms of treating gonorrhea? Well, all is not lost. A high proportion of gonorrhea isolates are still very sensitive to the old drugs that we've used for gonorrhea. So if we actually know that an organism is sensitive, we can still use a drug like ciprofloxacin, which is actually a really good drug for gonorrhea. And probably 2/3 of our gonorrhea that we see in the UK, you could still use ciprofloxacin up front if you knew the bug was sensitive to it. Other old drugs like gentamicin and spectinomycin still have excellent efficacy against gonorrhea strains, but unfortunately they're not so effective for throat infections, irrespective of the resistance patterns, and that does limit their use somewhat, particularly in MSM. Now, there are some newer drugs that still have 100% efficacy against all gonorrhea strains seen so far, but further work is needed to guide optimal dosing of these and whether or not they will be best used as a single agent or in dual regimen. So drugs like ertapenem, solitramycin, and 2 new drugs that have been in the pipeline for a while, Gepotidacin and zoliflodacin, and they've all undergone clinical trials for gonorrhea in recent years. Some interesting work's been done in Melbourne looking at antiseptic mouthwash to see whether it can prevent throat gonorrhea in MSM, and it'd be great if that does work. And also some preliminary data suggests that meningococcal vaccination offers some cross-protection against gonorrhea. So further trials of vaccination are awaited, because that would be a fantastic way of controlling gonorrhea infection. Now, it's not all about gonorrhea. What about syphilis? Well, unfortunately, this old foe is still endemic in many areas of the world. And despite declining rates in the late 20th century, it re-emerged in Western settings over the last 20 years or so in men who have sex with men, and now it's an infection that we're seeing every day in this population. And sadly, the scourge of congenital syphilis is once again being seen in the USA and in the UK, although the highest population rates are still seen in Africa and South America. And those figures there from the World Health Organization, which show this enormous number of preventable fetal, neonatal and infant deaths, are really quite staggering, considering how easy syphilis is to test and treat by our standards. Looking at this graph, you can see those parts of the world where congenital syphilis is still a daily occurrence, and certainly much more work is needed in this regard. Locally in the UK, this graph captures our own experience with early syphilis diagnoses recently, where there's been a low but steady number of cases occurring in women, but an ever-increasing number of cases occurring in men, and these are mostly MSM. And perhaps this is the same experience for many of you who are listening today. Of course, syphilis still does what it does best, and that's to imitate just about any other disease, and so it continues to show up all over the hospital. And in particular, in the last decade, there's been a sharp increase in ocular syphilis that's been seen in many different settings in Europe and the US, where the MSM epidemics in syphilis have occurred. Now, fortunately, good old penicillin maintains its activity against syphilis, and it's still our first-line treatment for this infection. So weekly injections of benzathine for uncomplicated infection, although for neurological or ocular disease, we have to resort to using daily intramuscular injections of procaine penicillin or intravenous aqueous penicillin for treating these manifestations. We have seen that most of the local strains of syphilis that are circulating amongst MSM have been selected out over the last couple of decades to be resistant to macrolides, which is a shame, because azithromycin has been able to be used to treat syphilis in areas such as Africa. But fortunately, doxycycline remains a very useful second-line therapy where penicillin can't be used. The big threat with penicillin is that the very real possibility of stockouts of the long-acting penicillin, benzathine penicillin, and this it has occurred in our first world settings as well as in resource-poor settings, and it really threatens our ability to manage this disease, so we need much more benzathine. Now, in terms of the diagnosis of syphilis, well, it has evolved, and yet we're still relying on 100-year-old tests in many settings to diagnose syphilis. Dark field microscopy, it's a disappearing skill, but those of us who can still remember how to do it find it a useful test, but it's really only if you've got lesions that are present in patients and a good microscope. And even in the best hands, its sensitivity is probably only about 70% or less. In recent years, the use of PCR to detect specific Treponema pallidum DNA has been successful, but unfortunately it's not yet a commercially available test, and so few of us have access to that test. PCR has been used on blood as well, but its sensitivity in most settings is quite low. For histopathology samples thought to contain syphilis, there is an immunohistochemistry stain for spirochetes that has helped pathologists to diagnose syphilis, but of course you need biopsy tissue for this, and you also have to think of the diagnosis first, but it's worth alerting your histopathology colleagues to this test if they're not aware of it. Serological tests remain the mainstay of screening for syphilis, and some of the older tests, such as the FTA absorption method, have given way to the more automated assays, such as EIA, for the detection of specific Treponema pallidum antibodies. Now, false positives do occur with the EIA test, and so we still need to use the more specific assays, such as TPHA or TPPA, and they're essential for confirming syphilis. And of course, we still rely on the non-specific cardiolipin antibody tests, such as the RPR or the VDRL, to monitor disease activity, response to treatment, and also to detect reinfection in people who've previously had syphilis infection. Now, some attempts have been made to automate these non-treponemal tests in recent years, but this has been done with limited success. So I'm sure every lab is probably still familiar with the macroscopic RPR cards that you can see there on the slide, or the use of VDRL slides for the microscope. Now, one important breakthrough in the last decade has been the use of rapid syphilis point-of-care tests. And these simple lateral flow assays can detect specific treponemal antibodies, and a few of them have also been enabled with a non-specific antibody component, although those with a non-specific component aren't necessarily more effective in some settings where over-treatment of syphilis is common, regardless of what tests you use. But these tests are easy to use, they're inexpensive, and in some of the tests they've been incorporated as dual HIV and syphilis antibody tests, and this is especially important in antenatal settings where HIV and syphilis infections in neonates can be prevented with the use of these simple tests. Where they've been used and assessed in the field, there are some drawbacks of both underdiagnosis and overdiagnosis, but overtreating for syphilis in these types of programs is generally acceptable given the lethality of the disease, especially its effect on babies. Now, what about Chlamydia trachomatis? Genital chlamydia is a really high prevalent infection in most populations globally, and typically it affects adolescents and young adults, although it tends to be seen more across the age range in MSM, and it occurs much more as a rectal rather than a genital infection in them. Recent studies have shown high rates of rectal infection in young women as well, and rectal infection in women might be an important factor both in treatment response and the ability of chlamydia to persist, and you'll see more research being done on this important area as time goes on. Now, PID in women remains the biggest problem caused by chlamydia, along with epididymitis in men. But even following successful treatment of PID, the adverse outcomes that are seen in women, such as ectopic pregnancy, tubal factor infertility, and chronic pelvic pain, do result in much morbidity, and they're very expensive to manage in most settings. Neonatal eye and lung disease can result from untreated chlamydial infection in pregnant women as well. This graph from the surveillance of chlamydia in England in 2017 shows the typical age peaks of chlamydia in the late teens and early 20s. And screening programs for chlamydia in these age groups have been recommended, and they have been implemented in places like the UK. As far as diagnosing chlamydia, whilst culture for chlamydia used to be used extensively for testing, it's rarely done these days, and it's been superseded by chlamydia NATs, and in most settings that's what is used to diagnose chlamydia. Rapid NATs are starting to appear. Sadly, some of the non-amplified rapid tests that were developed have performed very poorly for chlamydia and can't be recommended. We prefer non-invasive specimens for testing for chlamydia these days, so urine in men and vulvovaginal swabs in women, rectal swabs in men who have sex with men and in women, and these are indicated from recent studies even when no anal sex is reported, because they do have an increased pickup rate for chlamydia in women. Doxycycline and azithromycin are both still effective for chlamydial infection, as no pre-resistance has been reported in chlamydia. But many recent studies do suggest that a stat 1 gram dose of azithromycin might be less effective, and it's especially for rectal infection, and doxycycline is preferred in this situation. And it probably also works better for symptomatic male urethral infection as well. But basically, we use doxycycline first line for all chlamydial infections unless it's contraindicated, and some guidelines are starting to reflect this as well. And once again, in MSM, if you're not testing extragenital sites for chlamydia, you're missing the majority of it. And you can see here from these figures from that same study that we did in London, the rectum is by far the most commonly affected site with chlamydia in MSM. Now, lymphogranuloma venereum, or LGV, is chlamydia as well, but just not as we know it generally. It's caused by the L serovars of chlamydia, and these infect lymphoid cells rather than mucosal cells, and thus they can produce a tissue invasive infection with much more severe clinical features such as genital ulcer disease and lymph node disease that can cause buboes and scarring. Now, traditionally this is seen mostly in the tropics, where it still occurs, and it's usually managed syndromically in these settings. However, LGV, whilst historically had been seen in MSM, as recently as the 1980s, it more or less disappeared, but around 15 years ago, it was detected once again in Europe, and it's once again become endemic in the MSM population, where it occurs mostly as a rectal infection, and it's most likely to be symptomatic as a severe hemorrhagic proctitis. It's strongly linked with HIV positive and Hep C positive populations, and with those MSM who engage in chemsex. But it's an infection that can be seen across the board in MSM. Its symptoms are often so severe that it can be confused with inflammatory bowel disease, and delayed diagnosis of LGV is likely if patients are seen outside of a sexual health setting and STI testing is not offered. Some recent large European studies have shown that LGV can actually be carried asymptomatically in up to 30% of rectal infections in MSM, and this is probably key to its persistence. Now, LGV can only be confirmed by the detection of one of the L serovars of Chlamydia trachomatis. Now, all chlamydia gnats should be positive in LGV-containing specimens, but you do need to do an additional specific LGV DNA test if you want to prove that it's LGV. And unfortunately, there's no licensed commercial assay for this, and so in most settings, this will be done with the use of an in-house assay or referral for a reference lab test. The main difference with the management of LGV is that longer courses of doxycycline are recommended, although we have published recently that as long as you use at least 7 days of doxycycline, in most cases, you're probably going to clear the infection. And here's just a graph that shows the numbers of cases over time since 2003 in the UK, and clearly this is an infection that continues to persist and increase in recent years. All recent cases have been in MSM, and most of them have been HIV positive, and other European countries have seen very similar patterns of infection. Moving from LGV to Trichomonas vaginalis, and this is the most common curable STI globally, but most of it actually occurs in resource-poor settings. We do see Trichomonas in Europe and in the UK, but mostly in our own settings, it's seen very clustered in specific populations. And for instance, in the UK, and particularly in South London, where I used to work, we saw TV every day, but it was much, much more prevalent in the Black Caribbean population. And also somewhat in the Black African population. It also tended to occur in older age groups than the other bacterial STIs, and it was often asymptomatic. And whilst it's rarely associated with any really serious direct adverse outcomes, it is a major cofactor for HIV transmission, and it also has a strong population effect on reproductive health in women. And so it is an important infection. As far as diagnosing TB, most of it is seen in resource-poor settings, and thus it's managed syndromically. But microscopy is a simple and cheap test that is quite effective, but its sensitivity is low compared to the more modern tests. But sensitivity is up to about 70-75% in symptomatic women where it's done on a fresh sample. And it's still a test that we use in clinic and find useful. But just because the wet mount is negative doesn't exclude trichomonas infection. So having another test for certain populations is important. Culture is often done, but it's quite resource intensive. There is a new rapid antigen-based test, the Awesome test, which certainly seems to have very good sensitivity, and it's quick and easy to use, and is being used successfully in many sort of non-lab settings. But it's great to see that TV NATs are now available on some of the commercial platform. Now, these tests have the highest sensitivity, and they can also be used on the same samples as the CTGC NATs, and can even be multiplexed with these assays. Some recent studies have shown poorer clearance rates with metronidazole treatment, especially the 2 gram stat dose, and week-long courses of metronidazole are now recommended. You can also use tinidazole, which is probably a bit better, but there are a few other reliable antimicrobials for Trichomonas, and certainly more study with newer agents are needed for this very prevalent infection globally. Now, Mycoplasma genitalium is another bug. If you haven't heard of it before, it has been hitting the headlines recently, and it's also now purported to be one of these superbugs. Now, M. genitalium is a proven cause of non-gonococcal urethritis in men and has strong associations with cervicitis and with PID in women. But only recently have commercial assays become available for M. genitalium, so there's still not much testing going on. But wherever studies have been done, anywhere in the world, M. genitalium is usually proved to be a prevalent organism in sexually active populations, and it seems to have similar risk factors and similar rates to Chlamydia trachomatis infection genitally. The big problem is that its sensitivity to available antibiotics is falling rapidly, and the fear is that soon it might become untreatable. Now, NATs are the only reliable way of diagnosing Mycoplasma genitalium, and in addition to a NAT result, for optimal management, we may also end up requiring molecular analysis to look for resistance-associated mutations, because these can help to predict which drugs will be effective for M. genitalium. And unfortunately, the most recent studies that we look at show that at least 50% of strains are resistant to macrolides, and we used to rely on azithromycin to treat Mycoplasma genitalium, but unfortunately it's unlikely to work in many settings now. And the only other drug that was reliable was moxifloxacin, but now at least 10% of strains in these settings are now resistant to these quinolone drugs. And so we're really wondering where we're going to go next. I mean, doxycycline does work for Mycoplasma genitalium, but probably only in about a third of cases. And there are really few other drugs with proven efficacy. So watch this space, but the future does look a little bit grim for M. genitalium. Now, herpes simplex 1 and 2 infections have always been highly prevalent viruses, and HSV2 has usually been responsible for most symptomatic genital herpes disease. But in recent decades, in many settings, there's been a big shift towards HSV1 causing the initial episode herpes in young people. And seemingly this is due to a fall in childhood infection with herpes simplex type 1. So fewer people have cold sores, and therefore they are more susceptible to getting herpes elsewhere on their bodies. Now, in our local setting here in Northern Ireland, when we've reviewed it recently, about 80% of our initial episode genital herpes cases test positive for HSV1 rather than HSV2. Now, fortunately, HSV1 is a much less recurrent infection than genital HSV2, so perhaps it's not such a bad thing. But testing for herpes does rely on type-specific herpes NATs, and these are much more sensitive than culture, and there's several commercial assays that are now available. In resource-poor settings, syndromic management of genital ulcer disease does need to cover herpes, as this is an increasingly common cause of genital ulcers, especially since other causes like chancroid have been falling. Acyclovir and related drugs, valacyclovir and famciclovir, are still the main treatments used, but disappointingly, we still await an effective herpes simplex vaccine. Now, human papillomavirus, or HPV, is probably the most prevalent STI globally, and many of the more than 150 strains of HPV are transmissible sexually. And genital warts, as well as some anogenital and other cancers, are caused by HPV oncogenic strains. Now, most HPV is asymptomatic, and warts, whilst they're not particularly dangerous when they do occur, they do cause much morbidity in adults, and particularly psychosexual impact on particularly young adults is something that we continue to see. There's, of course, continues to be an enormous global cancer burden from the oncogenic strains of HPV, especially type 16 and 18. But in the last decade, there's been major successes that have been seen with the use of HPV vaccination, and not just for the high-grade precancerous lesions and cancers, but also for genital warts where the quadrivalent vaccination has been used. And it's now a high priority to roll out this vaccination to all those populations still at risk. The newest version of the vaccination is now non-valent, and so it offers even greater protection against a wider range of the oncogenic strains of HPV. Now, just looking at diagnostic testing overall, I mean, it's important to think of it in terms of the two parts of the world. In resource-poor settings, depending on the setting, the opportunity to actually diagnose STIs might be completely absent due to the lack of skills or the lack of diagnostic equipment. And so many patients are managed syndromically. But unfortunately, many of these syndromic algorithms have very poor specificity. And the high rates of asymptomatic STIs mean that a huge burden of disease is simply never detected or treated, as there's very little screening available. One of the problems is also that in many regions of the world, over-the-counter consultations in pharmacies or in markets and provision of antibiotic treatments are common, and this often results in mismanagement and very poor antibiotic stewardship. And I'm sure that decades of this practice have likely produced some of the extensively drug-resistant organisms that we're currently facing that I've discussed. Point of care tests for HIV and syphilis have certainly already been implemented with much success in resource-poor settings, and other point of care tests are emerging, and we really look forward to the use of some of these other rapid tests in this setting. But a quote from WHO in a recent report that points out that a major barrier to advancing STI control and prevention is the lack of reliable, low-cost point-of-care test. I think that really encapsulates one of the big problems in resource-poor settings. But in resource-rich settings in our part of the world, we're very fortunate to have access to a variety of modern diagnostics, and many of them are now molecular assays as molecular tests start to take over some of the more traditional methodologies. But culture still remains very important, and particularly in gonorrhea for antimicrobial resistance surveillance and for the management of individual patients. But better assays and research has enabled us to use non-invasive sampling and self-sampling in settings remote from the clinic, and this has certainly helped to modernise many pathways for STI care and expand access to screening. Clinical pathways have continued to be improved by shorter turnaround time for results, and now the emergence of rapid tests certainly has the potential to enhance our local clinical services as well in the resource-rich setting, not just in the resource-poor settings. We're also beginning to see clinic-based lab spaces expanding, so the sort of removal of the gap between the lab and the clinic, and as well increasing use of multiplex assays is starting to make life easier, and innovations like pooling that I've mentioned before can also help us to use these assays in more affordable ways. In the future, I think molecular antimicrobial resistance testing will be of increasing importance for some infections, and we need to continue to work with the test manufacturers in this regard. Now, I did want to add just a couple of slides just to discuss some key related conditions. First of all, in women, genital symptoms can be related to common conditions such as bacterial vaginosis, candida, and to a lesser extent, aerobic vaginitis. Now, whilst they're not considered to be classical STIs, although you could argue that bacterial vaginosis probably is an STI, they do occur commonly in women who are sexually active, and they could contribute substantially to quality of life issues for women. In resource-poor settings, they also impact really significantly on the syndromic management algorithms, particularly for things like vaginal discharge, and specific diagnostic solutions are required in all settings for these conditions. In addition, the population effects of bacterial vaginosis and HIV transmission and the reproductive health outcomes in women are really substantial. And vaginal dysbiosis, I think, is every bit as important as STIs at this global population level. And in the future, I hope there are even better diagnostic and management solutions for this. In addition, men who have sex with men remain one of the key population in all regions of the world when it comes to STIs. And the syndemics of HIV, sexually transmitted infections, and recreational drug use are really complex. And the interplay of these needs to be recognised when managing MSM in the clinical setting. The impact of pre-exposure prophylaxis, or PrEP, for HIV will also be substantial. Now, not only because it will almost certainly reduce the incidence of HIV in various populations, but it does have the potential, I think, particularly in MSM, for changes in sexual behaviour that favour a rise in the incidence of other STIs. And that's something that many clinical services that see MSM on PrEP have actually become to see. So in a way, it's probably the perfect storm for some of the problems with STIs and resistance. As I've mentioned before, MSM have multiple potential sites for STIs, and in practice we often see multiple concurrent STIs in the same patient. And in addition, we see extra organisms such as gastrointestinal pathogens behaving in it as STIs in MSM, and Shigella and hepatitis A are two examples of such. And this all creates a lot of clinical complexity, and in many settings this may warrant additional training for staff and additional resources in order to optimally manage MSM. And also managing MSM with recurrent bacterial STIs on a background of increasing resistance means that good antibiotic stewardship is really critical, and I think there needs to be much greater attention to this internationally. So, in summary, that was a bit of a whirlwind tour of some of the issues surrounding STIs in the current clinical environment, certainly from my perspective, and things that I see my colleagues dealing with. And clearly, STIs continue to impact global health in a big way. It's not just the same old foes such as syphilis and gonorrhea, but they're newer pathogens like Mycoplasma genitalium, which are creating additional challenges. As organisms become resistant to current antibiotics, we need to find new strategies to manage bacterial infections and try hard to preserve the precious drugs that we still have available to us by the stricter and more prudent use of these drugs. And this is especially a challenge for resource-poor settings, as I mentioned. But even in our own setting, with all of the modern tests and the laboratory and all of the treatments we have to hand, STI rates are still increasing. So it's evident that new approaches are required. So new tests, new treatments, innovation, and in particular, I think we need to engage effectively those very risk groups that are the ones that we're seeing most commonly. And if we do that, I think this will be key to success in managing STIs going forward. So that's enough from me. I'd certainly like to open it up to the floor and see if there are any questions or comments, and I'll hand back to the moderator. Thanks, Judy.
Thank you, Dr. White, for your presentation. A quick reminder for our audience on how to submit questions. Simply type them into the drop-down box located on the far left of your presentation window labeled Ask a Question and click on the Send button. Dr. White will answer as many questions as time permits. The first question is, there are a lot of collection devices specific to the anatomical site for each bug. How difficult is this to manage at your clinic, and what recommendations or changes would you like to see in this area?
Okay, thanks, Judy. That's an important question, and I think it really will vary according to where you're working and what assays you're using, both in the laboratory and just locally in clinic. Certainly, there's been a move towards some multi-collection devices in some of the commercial assays in recent years, and I think this is really helpful to have one swab that can be used for an endocervical or a vulvovaginal specimen, and to be able to use that same swab for a rectal swab or a throat swab, I think makes life a lot easier rather than fumbling around with different swabs trying to find the right one. Going forward, I think that commercial assays, especially when they're multiplexing and testing for multiple different pathogens in the one assay, this enables us to use a single specimen rather than taking a lot of different tests to test for the different organisms. And similarly, if you're using urine as a specimen, being able to use that or to pipette the urine into the same tube for analysis, I think that makes life easier. But yeah, I think that for some people, if they're having to test for 5 or 6 different things in the one patient, sometimes they might still be forced to take 5 or 6 different specimens until there's one test that really enables us to test for everything in the one specimen.
Thank you. How could molecular diagnostics testing help improve your clinical treatment decisions?
Well, I think we've been seeing the impact of molecular diagnostics improving our clinical care of patients for many years now. I mean, with probably the first nucleic acid test that we used widely was the chlamydia test, and I think once we started to use chlamydia on gnats, we realized just how much chlamydia we were missing using some of the much less sensitive tests, and some of those tests had specificity issues as well. And so, we could be a lot more certain when we were treating people for chlamydia that the people truly had the infection and that we weren't missing any infections. And I think that the same still holds today. If you're using culture to test for gonorrhea only, I think that, as I've sort of pointed out in some of those slides, you're missing a lot of infection potentially, and really to detect as much infection as possible, the molecular assays are going to enable us to do that. Because a lot of patients, they don't want to be diagnosed with something. They really want to be told that they don't have anything, and to be able to really reassure patients, particularly those who might come in as advised for an STI screen. Our ability to be able to say, look, you've got the all clear, it really depends on the sensitivity of the assays that we use, and molecular assays certainly have the best sensitivity in that regard. And then when you're looking at organisms like Mycoplasma genitalium, there really are no other options apart from treating people syndromically. And when you diagnose a male with urethritis, if you don't know whether it's Mycoplasma genitalium, giving the appropriate treatment these days is just becoming increasingly difficult. I think that there's still an important role for a lot of those other tests, but molecular tests are really making our life easier, but they're also improving the outcomes for patients and giving the patients what they want, really, which sometimes is just to be told they don't have anything.
Thank you. We're getting so many great questions coming in. The next one is, if a patient is positive for chlamydia but negative for gonorrhea using NAT, would you treat for both ceftriaxone? Would you treat for both? For example, include ceftriaxone IM or only for chlamydia?
Well, it's a really pertinent question, because I think that the use of really important antibiotics like ceftriaxone, I think that whilst we've been throwing this drug around for decades, and it's still very useful to treat a wide range of non-sexually transmitted infections as well, in the STI setting, we really want to only be using ceftriaxone for people who we know have a gonococcal infection and not treating people who don't have the infection. And bear in mind that a lot of people who don't have the infection, they may still be at high future risk of gonorrhea, and therefore by exposing them to antibiotics that have important activity against gonorrhea, we may be actually doing those patients a disservice by enabling them to develop resistance to those drugs in other commensal organisms, which then could be transferred to gonorrhea if they did become infected at a later date. And so I think the stewardship of only using drugs like ceftriaxone for patients where there's a really strong indication for it is what we should all be aiming for. But clearly, we've had a very defensive prescribing practice for many years now, either because we don't have the test to be able to confidently exclude infection, or because a patient may present as a contact of gonorrhea, so they've had sex with someone who's had gonorrhea diagnosed, but we don't know if they've got gonorrhea or not unless there's clinical signs. We have to wait for their laboratory results, and those results sometimes can take weeks to return. So having more rapid turnaround time for results can enable us to more easily defer treatment and reserve it for only those people who are infected. So at least in our settings, I think we need to move away from this syndromic algorithm where you think, oh, look, someone's got a discharge or someone's got some symptoms. It could be this, so let's throw everything but the kitchen sink at them. I think that we need to try to be really specific about the antibiotic treatments we use.
Thank you. Next one is, how big is a problem with gnats if you retest too soon, and how soon is too soon? And then secondarily, how does this vary with sites of infection?
Great questions, and not a lot of evidence to really answer them. In practice, yes, of course you can test too soon, and if somebody has been treated for an infection, for instance, gonorrhea, if they were given an injection for gonorrhea yesterday, we really shouldn't be able to detect gonorrhea today by culture. If the treatment's been effective, it's pretty quick to be able to kill gonorrhea, and of course, once the organism is dead, it can't culture. But we can still detect the organism the following day via the use of a NAT, and for several days afterwards, the nucleic acid can persist. I've seen it in individual patients where they've tested positive with a GC NAT at 2 weeks after they've been treated, and then several days later repeated the test and it's subsequently become negative. Most guidelines will say for gonorrhea, and particularly chlamydia, where there's a bit more experience, that after 2 weeks it's probably a reasonable time to be able to test. And if the test is still positive after 2 weeks, it probably suggests that they have a persistent or recurrent infection. But really, the evidence base out there doesn't include large studies. They're usually only relatively small studies. So, but certainly repeating a NAT test within a week of treatment is probably too soon in most settings, because interpreting a positive result in that setting is really going to be difficult. Certainly if it's negative, it's reassuring. But yeah, I think we need more studies for that. As far as other sites of infection, I mean, most of the studies that have been done have looked at genital sites in men and women. We've had some clinical experience with rectal and throat infections, and certainly in the throat, as I said, that One of those cases I was alluding to was a throat infection, and that it seemed that there was still GC RNA detectable after 2 weeks that subsequently became negative without treatment. But then sometimes throat infections clear without treatment anyway. So, yeah, I mean, that's just my experience. I don't think there's any studies to really say with any degree of certainty, but more work's needed.
Thank you. Next one is how effective are treatment options we have for multiple sexually transmitted infections in a given patient?
I suppose if you break it down by organism, I mean, in clinics, despite the threat of gonorrhea resistance here in Europe and in the UK, I mean, we're pretty close to 100% effective if we're using ceftriaxone, and the UK guidelines changes that are pending or more or less been drafted and implemented in the last few months. In the UK, we're now treating gonorrhea with ceftriaxone 1 gram as a single dose without any azithromycin co-treatment. And our experience on thousands of patients in recent years in London is that where we've only used ceftriaxone to treat gonorrhea, it's been pretty much 100% effective, because we haven't yet been seeing any ceftriaxone resistance. Now, that will change once we start to see more and more imported cases of resistance. But if you're working in the Far East, your clearance rate of gonorrhea with any dose of ceftriaxone is probably going to be lower. Chlamydia, I think that you're looking at still very good rates of clearance of genital chlamydial infections, probably close to 100% if you're using a week of doxycycline. If you're using a 1 gram stat dose of azithromycin, that might drop down to 90-95% for genital infections and lower for rectal infections, whereas a week of doxycycline still seems to work very well for infections at all sites. Trichomonas is a big problem, I think, in terms of treatment success. I think there's always been this assumption that, if someone's got trichomonas, you just give metronidazole, and if it doesn't go away, they've been reinfected. But in recent years, it's become very clear that treatment failure occurs quite readily, and we've got some data from London that suggested that the treatment efficacy might be somewhere only between 80-85%. And it seems to be lower if a single dose of metronidazole is used compared to a 5 to 7 day course of metronidazole. So longer courses of metronidazole are now recommended, but there's some cases, and we've all seen cases, where no amount of metronidazole or tinidazole will clear these trichomonas infections, and there aren't many other effective agents. We're having to resort to things like vaginal boric acid preparations and other not so readily available treatments. So I think that for such a common infection, there's a lot more work that's needed there. Herpes, pretty much, acyclovir still seems to work on all herpes in immunocompetent individuals. And yeah, I think for other infections, I mean, there are specific issues, but they're the main ones, I think.
Thank you. Are you seeing an increase in home collection devices in Europe, and what are some of the challenges associated with home collection, if any?
Yeah, I think that there's a number of programs now that are looking at sort of postal testing kits and people who can order testing kits over the internet or take testing kits home from pharmacies that they've purchased, and they collect the sample at home, and then it's sent to a laboratory for analysis. I think the positives of these are that the increasing use suggests that people are accessing these tests who perhaps aren't accessing other or testing in other sites, and that's great if we reach more of the population. I think the downside is it can be applied to, the risk of contamination and not collecting the samples, but that can also happen in clinics. I mean, I think that we need to be really fastidious about the way that we collect any specimen for a NAT analysis, because they are so sensitive. They can pick up contamination in samples, and it's impossible to tell if it came from the patient or the surface in the clinic where the swab was accidentally put. And so I think that having really clear instructions for both clinical staff and for patients about how to collect the specimen and how to use the devices in a way that means you get the best specimen for the laboratory and it doesn't contain anything that it shouldn't. But I think that that's probably the biggest issue. Or sometimes, people accessing tests perhaps that where they think that just by doing a test that they're testing for everything that perhaps they should be tested for, but clearly, depending on somebody's sexual history, there may be other things that are indicated for those patients. And so sometimes somebody just doing a test at home, they may think that that's all they need, but if they came to a clinic like ours, we might identify some other issues that we felt were really important, and they can't always be met by home sampling.
Thank you. It looks like we have time for one more question. Is it
Right.
recommended to test for Trichomonas vaginalis in males?
Recommendations are often based on evidence in terms of, okay, why should we test for an infection? If someone hasn't got symptoms or isn't complaining of it, therefore, is there any value in testing for it and treating it? In Trichomonas, it's an interesting infection because men are probably only transiently infected in a lot of cases, and women tend to be the reservoir of infection in terms of they have long-standing infection, which may be symptomatic or asymptomatic. And men with Trichomonas, they would usually get urethral infection, which may cause a discharge or dysuria, or it may be asymptomatic. And without testing and treatment, a lot of men would resolve their infections, but they may have the infection long enough to pass it on to another partner. So if you've got a population where there's a high rate of Trichomonas, I think it's really important to try to test men as well, because men are probably the vectors of infection. And I think if you can identify their infections and treat them effectively, and also through partner notification, try to access as many partners as possible who may have the infection as well, then I think that's the best way to go with Trichomonas infection. But I think you really rely on that testing in men because, in our experience, wet mount microscopy for Trichomonas in men has really quite a low sensitivity.
I would like to once again thank Dr. White for his presentation. Do you have any final comments?
No, look, I hope people have tuned in. I think that STIs globally are a really, really important issue that often don't get the press and get the attention. And if there's any laboratory staff out there, keep up the good work and keep fighting the good fight, because we rely so much on people that work in laboratories. And not all clinicians are as interested in lab stuff as I am, but we couldn't do the work that we do without all of the laboratory staff and all of those very clever assays that give us all the results. And so thanks again to all the people who work in the field. Thanks to Abbott for allowing this presentation to take place and for their ongoing commitment to diagnosing STIs as well.
Thank you. And I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today will be addressed by the speaker via the contact information you provided at the time of registration. We would like to thank our sponsor, Abbott Molecular, for underwriting today's educational webcast. This webcast can be viewed on demand through July 2019. LabRoots will alert you via email when it's available for replay, and we encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.